Awesome, thank you. So this evening we're going to be talking about PSA, which is procedural sedation and analgesia. It's a talk that sort of evolved over the years, I suppose, because it's such a practical thing that we're doing in the emergency department. Sorry, somebody just sent me a message. Okay, all right. So why do we care about it so much in emergency medicine? Well, pain is a big deal, right? And the definition of pain is sort of the physical suffering and discomfort that can be caused by injury or by illness. And it's a big deal to us, I suppose, in emergency medicine because we deal with patients that are in pain every day. And patients come to the emergency department because they want us to help with their pain. So that's kind of where procedural sedation analgesia comes in. Also, in the emergency department, we're often doing painful things to patients. So PSA is a tool that we really need to be good with in the emergency department. It's something that I try to teach my guys on a regular basis, that pain is actually a vital sign. You need to measure it, much like you need to measure the heart rate and the respiratory rate and the cap refill. But it's something that you actually have to record and document. So in my department, I've actually put it down as one of the assessments that have to be done when a patient is clinically being examined, particularly a child. So if you look on the second page of our clerking sheet, you'll see there's the FLAC score. Just as a reminder that, if you're not measuring it, how do you know if it's an improving? How do you know if it's getting better? Or how do you know if it's worse? So you have to measure pain to kind of know where we're at and what to do about it. Okay, so I mentioned the FLAC pain scale. There's lots of different scales. This is probably one of the most popular ones that's widely used in pediatric emergency medicine for assessing the behavior of a child in response to pain and how they are physically behaving. It's all very well an adult. They can tell us, I've got a pain 10 out of 10. Or pain 2 out of 10 on a pain score. But little kids often are sort of pre-verbal and they can't necessarily give us a good idea. But if you look at how they're behaving, their posture, their tone, their cry can give you a clue as to how bad their pain is. And then we can also assess, is it just mild discomfort, moderate pain, or is it excruciating pain? Can also be a little bit blurred in an ED because kids that are scared also very well might be behaving in a very squirmy sort of manner, whimpering, crying, maybe kicking or fighting. So there's also an element of fear in the emergency department, and we have to tackle it. But the way that I look at it, if a patient comes in and we're doing something, we're about to do something painful to them, we really need to anticipate that we are inflicting more pain, not just anxiety, and we need to do something about it. The Wong-Baker FACES pain rating scale is also another fairly well-described scale. I must be honest, however, whenever I show a kiddie this scale to ask them where they are, just the thought of being in hospital puts them usually at about a 12. They're terrified and kicking, and the Wong-Baker scale doesn't really show that. Just for the guys who are working with tiny babies, there's also a neonatal infant pain scale as well that also has a look at how they're breathing, how is their posture, what is their level of alertness, also to give us an idea about their pain scale too. So these are things that we need to document when we're seeing patients. Okay, so why do we care about PSA and what is it all about? Okay, and hopefully by the end of this, we'll be able to tackle a little bit more about what is analgesia, what is sedation, and then specifically what is procedural sedation and analgesia. I think one of the most OCD kinds of people would be a pediatric anesthetist. And often when you think about sedation, we're thinking about anesthetics, but it's not true. Something that we do pretty much on a daily basis in emergency medicine. We give sedation or sedating analgesics to patients. When we're trying to describe the depth of sedation, there's a scale. So you might be wide awake, Maybe there's some minimal sedation. So we might give something to a patient that just takes the edge off, much like an anesthetist might do if they're prescribing a pre-med for anxiolysis. Maybe there's moderate sedation. And in literature, you often see the term bandied around, conscious sedation. Dissociative sedation, often like what we see when we give ketamine. Deep sedation, so that's often where a patient very well might lose airway reflexes and will be deeply sedated all the way to general anesthesia. And so there is a scale sort of looking at the depths of sedation, and we might want to use these terms in emergency medicine, but to be honest, we very well might go all the way from anxiolysis to general anesthesia in a specific patient, depending on the condition. And that's kind of where procedural sedation and analgesia comes in. So looking at that. So when you describe what is procedural sedation and analgesia, and if you look at the ASEP policy, it's a management strategy for the safe administration of a sedative with or without an analgesic medication that varies according to the need of the patient and the procedure. We don't like the old-fashioned Brutalol, especially with kids. Don't want to hold the kid down or tie them down or wrap them in a sheet so that we can do something painful to them. Don't like this approach at all. Really do like to be mindful about what we're doing to patients. There's a different term that can be a little bit confusing when you are looking at this topic, analgosedation. And that's sort of looking more at analgesia and sedation that we might require for patients, for example, that are ventilated, either in the emergency department or in a critical care ICU environment, and the varying requirements of analgesia and sedation that are required for that patient to keep them comfortable on the ventilator and comfortable with the critical care interventions that the patient is undergoing sort of in an ICU or an ED ICU environment. Just something to think about, and it's an ICU concept that's really important in the ED as well. Patient might have pain, might be agitated, might be frightened, but they also might be sick. There might be a kitty with meningitis and we're about to do an LP. They might have delirium on board. All of these things can lead to agitation. A number of things can lead to agitation. So the whole idea of analgosedation is also important, not just looking at a once-off procedure that we're doing to a patient and then hopefully releasing them from their pain. But we might need to look at ongoing pain analgesic administration and ongoing sedative administration in the ED too. And this talk is not really focusing on this concept of analgosedation, but it's an important one for us in emergency medicine also to investigate and know more about. You need to document the level of agitation and sedation of patients. So if you have a ventilated child or a ventilated adult in the ED, it isn't good enough to write down the GCS as a documentation of the agitation sedation scale. You actually need to use something that is validated to help us decide how deep is this patient and do I need to add something to improve their level of comfort. We like to use the Richmond Agitation Sedation Scale, the RAS scale. It's not a new scale. There's many different scales, but this is probably one of the most widely accepted ones. And the reason that it's nice is because it has a look at how agitated is the patient. So if I've got a patient who's got a RAS of +4, I know this patient is probably going to yank out their tube. They're probably going to kick the nurse. They very well might pinch or bite someone if they can. All the way down to unarousable, a RAS of -5. We very well might not want a patient all the way to -5, especially if we're trying to wean them to extubate them because they've improved overnight, for example, and we're planning to extubate them in the morning. So this is an important scale, and it's a whole different talk on its own, but I thought I'd just bring it up because people often mix the concepts of procedural sedation and analgesia and analgosedation. Much like the RAS scale is used often in adults, it's also used in peds, but there is a really cool scale called the comfort scale, which takes into consideration the depth of pain or analgesia, as well as the depth of sedation, and also then puts them together and it's specifically designed for kiddies. So if you haven't heard of this one, this is one that's often used in the peds ICU environment. Okay, so back to procedural sedation and analgesia. Why exactly are we using it? And I'm going to put this question out, and I'm going to allow people to give me an answer as to why they think we're using PSA. Hey guys, why are we using? Hey, I don't know. Why don't you just tell me who is answering?
It's Dr. Saundi.
Hey, Dr. Soundy.
Basically for the comfort of the patient, not to traumatize them
Sure.
too much
And,
when
and
you
it's,
do the procedures.
yeah, and I think it's probably one of the most important reasons why we do it. We don't want to cause further stress to our patients, especially the little ones. But there's more than that, right? It's also for patient safety. We might be doing something that has got a high complication rate, like a central line. So if someone's wriggling and we put it in the wrong place, we can hurt them and cause further trauma or iatrogenic injury. But it's also for our own level of comfort. I can't stand doing painful things to patients if I haven't done something to take the edge off for them or administered really good analgesia. As a EM doc, I can do any number of painful procedures as long as my patient is adequately analgesed plus minus sedated. I actually want to barf if I walk in and a child is being held down. It's one of the things that actually makes me instantly nauseous. One of the other reasons that we want to do PSA is because we've got a much higher chance of successfully concluding our procedure because we've made it safe. The environment is safe. The patient is safe. I'm safe. I'm not about to vomit on my kid. And the kid is obviously comfortable. Okay. So what are the indications? Well, easy if we're about to do a painful procedure, but if we're doing scrub downs for burns, any kind of painful procedure, we are reducing a fracture. Maybe we are reducing a dislocation. Maybe we're doing a central line and intercostal drain, a lumbar puncture, suturing in kids, especially if they're tiny, and you're trying to calculate the toxic doses of lignocaine for the patient. You very well might run out of a safety margin. So we might go ahead and do procedural sedation and analgesia anyway, lengthy wound debridements, but also maybe I'm doing it for something like analgesia and sedation for pacing. Or synchronized cardioversion, or for keeping a patient comfortable on a ventilator. So lots of things that we do in the ED very well might be assisted by adding PSA. Okay, so this is a very simple ABCD approach to how do we do procedural sedation and analgesia. Obviously, take a big breath and have a nice approach. Okay, so first assess the level of analgesia and agitation. Do whatever your interventions are, and we're going to talk about that now. Reassess the patient. See how is their pain? How is their agitation? How is their level of sedation? And what do I need to do to keep them comfortable if I need to add something more, if I need to do a further intervention or monitoring? Okay, so have a systematic approach. I like the ABCDE approach. Pretty much everything in emergency medicine is ABCDE. So assess the patient, have some kind of backup plan, know the background and history of the patient. Got to take consent. So written consent from a patient, written consent from a loved one or a parent. Know your pharmacology. Make sure that you've got all the equipment that you need. Look at your fasting guidelines, and then also have a look at when can we safely discharge a patient. There's a checklist, and there's lots of checklists around. I like this one just because it's one of the ones that was in a protocol book from many years ago that I really liked. It's a one-pager, and I like one-pagers. And pretty much it takes you through the ABCDEFG of procedural sedation and analgesia. Assessment, have a look at the patient, and we're trying to assess clinically and physically and on history, how risky is it? So we're trying to have a look and see, does the risk of providing deep sedation to this particular patient outweigh the risk of actually doing the procedure in the ED. So we're trying to assess, is it very risky for us to do it, or is it more risky not to do it? And we well might need to look at the ASA physical classification that the anaesthetists use. Got to do an airway assessment, got to do a good clinical exam, take a good history, particularly a patient's response to previous anesthetic or analgesic agents, allergies, and then also go hunting for risk factors. So just don't take PSA lightly. It's never a good idea to ask the nurse to give ketamine, leave the kid in a side cubicle, and walk away while we're waiting for the ketamine to kick in. Understand that there are adverse effects and know how to deal with them. If you follow guidelines, the person doing the procedural sedation is not supposed to be the person doing the procedure. However, in emergency medicine, we might need to give the procedural sedation medication and have a nurse sit with us while we're doing the procedure, and then we move on to doing the procedure. So try and have a second person that can assist you should you need to intervene for the patient. Okay, try to make sure that you've got everything pre-planned and pre-prepared, because if you do, things probably won't go badly. If you haven't, you're probably going to experience an anaphylaxis or an airway compromise that you hadn't planned for. If you're worried about the patient or if there's any risk, it's a high ASA classification. This patient needs to probably be done in theatre. The procedure needs to be done in theatre with an anaesthetist. So don't go jumping in where the patient has got congenital cardiac conditions or has got horrible airway anatomy. Don't go there with your fentanyl and propofol. Not a great idea. Okay. As I said, consent must be written. You've got to discuss what's going to happen, the most likely complications, alternative options, okay, and warn them about the side effects of the medications. Okay, got to know your pharmacology thoroughly. I'm not going to talk in detail about the pharmacology, but in EM, we've got to know all our drugs, your doses, and the potential side effects of your medication. Okay, equipment. Obviously, we need to be trained. Your assistant, whether it's your intern that's helping you or your nurse that's helping you, you need to also share your mental model with them about what the plan is. But have airway equipment. So it's nice to do it in the resuscitation bay where we've got monitoring, our resus trolley handy, our laryngoscope, our BVM, oxygen, suctioning, and all other monitors that you very well might need. Okay, with regards to fasting, when it comes to procedural sedation and analgesia, there isn't really a plan for us to intervene with the airway. So it's not like an anesthetic where the patient is being put to sleep. We want to keep them NPO so that they've got an empty stomach. We particularly are trying to give a procedural sedation and analgesia, and we don't want to mess with the airway. We want them to breathe by themselves. So you don't have to have an NPO patient, and the NPO guidelines for PSA are not the same as the NPO guidelines for general anesthetic. However, you do need to be mindful. So if your patient has just eaten a big KFC rounder and a double thing of chips, and you are about to do an IND on an abscess, as long as this patient is stable from their abscess, you can probably wait a couple of hours for the intervention to be safer. So we're looking at the risk versus the benefit. And that's always important when you are looking at fasting guidelines. Particularly with PSA, we don't want to mess with the airway. We usually want them to keep breathing by themselves. We don't really want to have to do airway interventions on the patients. Okay. And then guidelines for safe discharge. Obviously, the patient has to be awake. Their vital signs have to be returned to normal, adequately hydrated, appropriate. And we should be able to give good discharge instructions. If we're letting the parent go home or the patient go home, then there must be safe discharge instructions for us to give to the person who's going to look after them at home. Okay, so looking at the ASA classification, ASA 1, there's no disease, all the way to ASA 5, where the patient is sincerely dying and is really on their way to heaven. And that's probably a patient that we don't want to do PSA on. That person probably should have something different done, and procedure should probably be done in a theatre with an anaesthetist. That's not always possible, obviously, under our circumstances, but it's just to remember that it's probably safe to give PSA to a patient who's an ASA1 or an ASA2, well-controlled disease. We're not going to necessarily go and give a PSA to somebody who's got life-threatening bronchospasm. We're not going to go and IND their abscess right now. We're going to let them sort out their life-threatening condition first. Airway assessments, have a look, see if they've got like a Pierre-Robin syndrome, so those tiny little chins, very large tongues. Do we have a patient who's had a previous tracheostomy? So do some kind of airway assessment properly, looking at your Mallampati scale, like we do for sharks. Okay, so do whatever measurements and assessments, because if you do have to intervene, you need to know, will I be able to safely bag mask ventilate this patient? Will I be able to safely intubate this patient should I need to? Don't forget to have a look for the pathology. People often underestimate how difficult it might be to do airway interventions in a patient. And then have all your backup devices ready. So you need to have your LMA ready, maybe your video laryngoscope handy, a bougie handy in case you have to go into the dreaded airway. Okay, monitors obviously need to have full monitoring, SATs, pulse oximetry, obviously, heart rate, BP is great. If you've got capnography, it's the ideal tool, especially if you've got nasal non-invasive capnometry. That'll be a really great idea. How can we administer our procedural sedation analgesia? Well, there's lots of different routes. Intranasal, IV, oral, parenteral might be used in patients that are getting painful procedures, for example, done in the dental clinic. They might have some oral analgesics administered. Maybe kiddies going for CT scans might have an oral sedative administered because it might be an elective CT scan. So lots of different routes that we're going to look at. Don't forget the intranasal administration can be very effective, especially with fentanyl. It's a great tool to use, especially for kids with burns. So don't forget about this device as an adjunct to your procedural sedation and analgesia. And how do we use it? Well, number one, have the device, or you might have to look and see how can I atomize, or how can I make my own atomizer. As I mentioned, know your pharmacology off by heart. It's not something to be messed with. You can't make up the doses. You have to know them. And obviously check. So check the doses, open up your dosing card or your app or EM guidance, whatever you're using to help you if you can't remember off by heart. Phone a friend. Okay, I love ketamine. Ketamine is amazing. Obviously, I work in pediatric emergency medicine. So ketamine we use all day, every day, for pretty much everything for kiddos. And it's very safe in small people. And yeah, it really is the drug of choice in peds emergency medicine. In adult emergency medicine, we've got a lot more drugs. So etomidate, propofol, you might be in an ICU environment and have access to dexmedetomidine. So there's lots of different things that can be used. Maybe we're going to use ketofol, something we tend to use a little bit more in adult emergency medicine than in peds. Okay, maybe we're looking at our combination agents. So please remember that very often the sedative agent you're giving doesn't have an analgesic on board, or the analgesic that you're giving might not have any sedative effects, which is why it's good to know what are the combination agents. So ketamine, dexmedetomidine, and clonidine. Interesting, clonidine is now on the essential drug list, so the EML essential medication list. And is approved in pediatrics for analgesia, but it also has a sedative effect too. Methoxyflurane, fantastic for those of you who have access to it. Obviously, it's pretty expensive. When I last priced it, the price has come down in private. It's about 550 Rand per pop, though, so it's for one patient and only pretty much for single use. So if you find that your EMS providers have brought a patient in on this, ask them to leave it for you, for the patient, so that you can continue using it if you need to. Really great analgesic sedative inhalational agent. In obs and gynae, they still might have access to nitrous oxide, which is something that they tend to use a little bit more at the coast or in our dental clinics, but so volatiles might be a route. So intranasal, oral, IVIO, intramuscular, buccal, inhalation. We've got lots of different routes that we can administer our analgesics and sedatives. Don't forget non-invasive techniques. So distraction, so having parents sing to the child, getting the kitty to count, having a nice environment very well might be good. Having a distraction technique like buzzy, or using ethyl chloride spray as a cold distraction technique. All of these things are important. Sucrose is also a distraction technique that's well documented in the tiny babies, the smallies. So neonates and infants, we might also use sucrose as a soothing distraction technique in addition to the analgesia that we're using. It's not instead of. I forgot to mention that splinting very often, or using a sling for neuromuscular injuries, can also be important. And probably the most important thing is positioning, keeping the kitty on mom's lap or mom right there holding them, so that we have the best response to our enteral or parenteral analgesic as well. So using a combination of methods is important. Okay, got to have a checklist when we're doing stuff like procedural sedation analgesia, because we're using pretty high scheduled medications. So much like they do in the aviation industry, use a checklist to make sure that they don't forget anything. We can also use a checklist, and I'd recommend using a checklist when doing a procedural sedation analgesia. We don't have a printer at my hospital, so it's really tricky, but in the ideal world, we should print out one of these checklists for every single patient and print out the consent form and add this to the patient notes, as well as document their vital signs during the PSA. So what are the complications of PSA? And I'm going to ask this of you guys that are busy listening. What are some of the things that can happen when we're doing a procedural sedation and analgesia in an emergency department?
Anaphylactic reaction.
Sure, okay. I've experienced an anaphylaxis with the kitty after ketamine, but the amount of ketamine that I have used over the years, it is so rare. I remember the patients who've had a ketamine anaphylaxis. I do not remember all the patients that I've given ketamine to. It's really pretty safe. Okay, other things that can happen when we're doing a PSA?
Airway compromise.
Of course, big one. And it depends on the agents that we're using, right? So if you're using propofol and opiate analgesic, you probably are going to lose your airway reflexes, and you very well might get hypoventilation as well. Don't forget that the alternative can also be true. We might not give enough sedation, so we might have them fairly light, and we're trying to do a very painful procedure, and actually they could laryngospasm on us. They could also have bronchospasm or bronchorrhea, airway secretions like from ketamine. So those things can happen. Other things that can happen from procedural sedation and analgesia, what else can happen?
So cardiovascularly, obviously if you use the incorrect doses, they can go hypertensive, bradycardic or tachycardic.
Yeah, of course. And so knowing your agents and how to administer them. So the rate at which we administer propofol is directly linked to the rate at which we develop cardiovascular effects. Same goes with fentanyl. You whack fentanyl in, they very well might develop symptoms fairly quickly and acute chest syndrome, so get muscular rigidity of their chest wall. If you administer fentanyl slowly, it's much less likely that you're going to have side effects associated with fentanyl. So the big ones on this slide, you can see the things that we need to worry about are the ones in bigger writing. The things that happen sort of more rarely are written really small on the screen. So you guys have mentioned pretty much everything here. Maybe the hypertonicity and the myoclonus. We don't tend to, or I don't tend to use a lot of etomidate for procedural sedation. Although I do know some emergency physicians who, if they're doing a synchronized cardioversion or pacing, might, something that they're hoping will respond fairly quickly, might use a dose of etomidate for. So it depends on the agent that you're using. Don't forget vomiting. So propofol is great. It decreases gastric it increases gastric motility, and it decreases the nausea and vomiting. However, ketamine, kids often vomit with it, so you need to warn parents. My big thing is loss of airway reflexes, airway obstruction, and hypoventilation, just because patients are sedated. So positioning of the airway is important. Making sure that you're doing a jaw thrust, or the person who's assisting you knows how to do a jaw thrust. So what do we do if we're running into problems with PSA? So, well, obviously stop the medication that you're giving. So if you're giving propofol and you run into problems, we'll stop. It's sometimes hard though, because we usually calculate a dose and give it. Position the patient adequately. So a kiddie, we might need to put something under the head, under the shoulders. Maybe we need to get a suction, do a jaw thrust. Maybe if the patient is having a laryngospasm, we need to put pressure on the laryngospasm notch. Maybe we need to insert airways, maybe an oral airway, a nasal airway. Reversal agents, I'm always loath to do that, because then whatever you've been doing, then you kind of are a step backwards. Then you reverse the analgesic, and now we're stuck. What do we give for analgesia? We reverse the sedative, and now I still need to do the procedure, but I've got a reversal on board. So consider the reversal agent. That's fine in an anesthetic environment if it's a elective procedure and they can just stop, right? For us, we usually have to carry on doing the procedure. So be very careful about reversing. Probably you're going to have to bag mask ventilate. Very rarely you're going to have to intubate. So use this stepwise approach and kind of know what to do. I get terrified when people administer ketamine and then leave a kid in a closed room with sort of just the mom watching them. I find that terrifying. But if you kind of know what to watch for, these things very seldom happen. Okay, so in a nutshell, the steps to procedural sedation analgesia: be prepared. Don't forget about consent. Explain to the mum and the dad or the patient what's going to happen. Brief your staff so they also know what's happening. You know, if you have a sister that's helping you, she might not know that ketamine can cause vomiting. So warn her, look, this and this is what can happen. Okay, go ahead, do your PSA, do your procedure, continue monitoring the patient. And then maybe you need to give further analgesia. Maybe you need to give further sedative down the line. So you might need to intervene again. And then obviously we need to monitor the patient until they're safely admitted or safe for discharge if they're going home after the procedure is finished. I like to think I'm the lady on the far right, haha. With great power comes great responsibility. So it's really not a complicated talk that I've presented. It's just like an ABCDE approach of procedural sedation and analgesia.